Thank you, Ashok. So welcome you all, friends, to this seminar on complex shoulder instability problems. It's a basically case-based presentation with some lectures in it, and this is being organized by Cure Academy. So we'll discuss most of the aspects of shoulder instability. And first, I start with Dr. Harjoban Singh. Dr. Harjoban Singh is a senior consultant at some Permanent Hospital, and he is basically into shoulder arthroscopy, shoulder arthroplasty, trauma, so everything related to shoulder. And he has done his fellowship from Aberdeen with Dr. Kapil Kumar, and now he's working as a shoulder consultant at some Permanent Hospital. Now he'll be speaking on assessment of shoulder instability, how you arrive at a diagnosis, because I think that's the most important thing in shoulder instability. So, Dr. Harjoban, if you're ready, then you can start your presentation.
Thank you, sir. I'll just share my screen first. So my topic is decision making in chronic anterior shoulder instability. Hello everyone. So as we all know, shoulder instability is most commonly anteriorly, and anterior shoulder dislocation results in a Bankart's lesion and a Hill-Sachs lesion. So Bankart's is basically a capsulolabral avulsion from the anterior inferior portion of glenoid, and corresponding lesion on the femoral head posterior superiorly is the Hill-Sachs. So if our job in Bankart's repair is basically to restore the anatomy, and if the anatomy is restored by labral restoration and capsular tensioning, we hope that everything goes well afterwards and this shoulder becomes stable forever. But this is not the case. When we go through literature, so there's enough studies in literature that show that arthroscopic Bankart repair has a failure rate of about average of 13.7%, but ranges from 7 to 20%. And this failure rate of arthroscopic Bankart repair goes up to 20 to 30% in athletic shoulders. So why do these arthroscopic Bankart repair fail? If we have restored the anatomy, then this should be stable, but they do fail. So Pascal Bolo in 2006 came out with risk factors for a recurrence of shoulder instability after the arthroscopic Bankart repair. And he also gave a percentage of risk involved with these surgeries. So first was the age of the patient at the time of surgery. If it is less than 20 years, the patient has a 31% chance of recurrence after Bankart's repair. If the level of sports participation is competitive, he has a 50% chance of failure after Bankart's repair. In patients who are involved in contact or overhead sports, there's a 33% chance. If the patient has a anterior or inferior hyperlaxity, he has got a 19% chance of recurrence. If you can see a Hill-Sachs lesion on AP view done in external rotation, there's a 31% chance of recurrence. And if the glenoid bone loss in AP view is visible, you can see the rounding of the inferior marginal glenoid on AP view. So this leads to a 37% chance of recurrence after arthroscopic Bankart repair. So basically, it is a failure to recognize the bony defect which leads to failure. It's not just a soft tissue lesion, but there's a bony element involved as well. So how can we assess the bony defects? First is the clinical assessment. It depends on the number of dislocations the patient had, ease of dislocation. Basically, some patients present with dislocation happening in the sleep that show that shoulder can come out so easily that it's very unstable. Ability to reduce themselves, prehension even at 45 degrees of external rotation, and the inferior laxity. So if any of these is present in your clinical history and examination, you should suspect that this patient has a bony defect as well, and you should go for a radiological assessment with X-rays, CT scan, and MRI. So Pascal Bolo came out with this instability severity index score in 2006, and this score, and he came out with a score to define patients of different grades of instability, and also suggested different procedures for different grades depending on the score. So first factor was if the age is less than 20, he gave 2 points, and if it is more than 20, 0. If the degree of sports participation is competitive, 2 points. Type of sport, contact or overhead, 1 point. Shoulder hyperlaxity, 1 point. And Hill sacks and glenoid glenoid bone loss available visible on the AP view, so 2 points each. If the total score is less than 3, so we can safely go ahead with the arthroscopic Bankart repair and with a less than 5% recurrence rate. And if the total score is more than 6, this patient has a 70% chance of recurrence after arthroscopic Bankart repair. And he suggested that these are the patients where we should directly go for letter J, open or arthroscopic. And in between 3 to 6, either you go for letter J or just do a augmented Bankart repair by adding remplissage. So this is a validation of the instability index severity score, in which the patients who had a score of less than 3 had a significantly lower risk of recurrence. So, once you have suspected a bony defect, either on the glenoid or the humeral side, you should know how to assess it. And this is very important. So that will help you in choosing the right procedure for the right patient. So evaluate bone loss on the glenoid and the humeral head side. So there are different methods of assessing glenoid bone loss. One is this PICO method, where we take end-face view of the CT scan and you draw a best fit circle over the inferior 2/3 of the glenoid. And you compare this with the opposite normal shoulder and assess the percentage of bone loss. And more than 20% bone loss is seen as critical bone loss. Taking it further, Yamamoto and Itoe gave this concept of on track and off track. And the glenoid track they calculated by so they related both the glenoid defects and the humeral defects together to came out with suggestions for treatment required. So glenoid track is 83% of the normal width according to their study. And if you see the figure in A on the top left, so you see the black line, this is a glenoid track on a normal shoulder, normal glenoid. And if you draw this on the humeral head, so black dotted line is the cuff insertion and black circle which is dotted is the Hill sacks lesion. If this Hill sacks lesion falls within the glenoid track, so this is called as on-track lesion. So in a patient, and if this Hill sacks lesion is outside the glenoid track, as shown in the lower picture, right? So this is called as off-track. And in a patient who has a glenoid defect as well, so you can see the glenoid track is also reduced. The white line is the 83% of the defected glenoid. So this white line is also reduced in size. So if you draw this line and see the level of Hill sacks which is going out of the track, so it is called as off track. So Yamamoto and Itoe came out with did a study and found out that patients who were treated with surgical options based on off track and on track concept, in them the recurrence rate was 4.3% at 2-year follow-up. And this was also reflected in other studies as well, who validated this on-track, off-track concept. So this study was by Joel Locker, and they assessed 100 patients of arthroscopic Bankart repair retrospectively with a mean follow-up of 22.4 months. And in their patients, the revision surgery was required in 6% of on-track lesions and 33% of the off-track lesions. So this on-track, off-track concept is very important to recognize the risk of instability after your repair has been done. Another study by Shekhar et al. Also validated this on-track, off-track concept in their patients as well. Overall instability rate was 18%. But when you further break down into on-track and off-track. So 6 out of 8 off-track lesions had a recurrence after the surgery. So the positive predictive value of an off-track measurement was 75% compared with 44% for the predictive value of glenoid bone loss alone, even if it is more than 20%. So combined off-track, on-track is better than taking just the glenoid bone loss. After we've done the radiological assessment, sometimes you can find surprises on arthroscopy as well. So you can assess the bone defects on arthroscopic assessment as well. Assess the tissue quality on the Bankart lesion, and also you can measure the bone loss on the glenoid side by looking from the anterosuperior portal and introducing a probe from the posterior portal and measuring the glenoid margin distance from the bare spot. So this will give you a fair idea of glenoid bone loss. And also you can assess the heel sacs and how medial it is. So basically, based on all these assessments, I've just tried to draw 3 different conditions where we can decide what treatment is best for that patient. So if the glenoid bone loss is less than 20% with a small heel sacs, which is on track, you can safely go ahead with arthroscopic Bankart repair. If your glenoid bone loss is less than 20% with a large heel sacs, which is off track, you have to do a augmented Bankart, like adding remplissage to the Bankart repair. And if your glenoid bone loss is more than 20%, or the patient has poor soft tissues, or it's a case of failed Bankart, you should consider lateral change in patients. So in conclusion, bony defect is the main cause of failure in Bankart repair. Clinical and radiological assessment is the key to recognize the bony defect. On-track or off-track concept gives you idea of both humeral and glenoid defects. And right procedure should be selected according to the patient profile and pre-op assessment. This will give you the best results. Thank you.
Thank you, Arjun. So the assessment of shoulder instability patients is, I think, most important, because that is poor selection of the procedure for a particular patient is the main cause of failure. Now, Arjun, of all the instability cases you operate, what percentage of patients do you do just Bankart? Just a rough figure.
So very less. I can't tell you the figure, but when I just go in and see a heel sacs, most of the time I would like to add a remplissage these days. But initially I just...
Of 100 patients, how many patients will get just pure Bankart repair, nothing else?
I would say not more than 30.
30%.
Yes.
Okay. Vikram, yours?
95%. I would say 98%.
Will get pure Bankart repair?
Yes. Arthroscopic procedure. Pure Bankart, I mean, of course, if you're looking at heel sacs, I'm sorry, I just got your question a little wrong. Pure Bankart, I would say 80% of my cases. About 10% more with added procedures like a slap or a remplissage, and maybe another 5% open.
Okay. So 80% will get pure Bankart.
Pure Bankart.
Manit, what's your figure?
I would say the same. 70 to 80% get pure Bankarts, and I think you're doing, Dr. Harjoban, I think you're doing too much remplissage, because if you look at the data on the on-track, off-track, so the number of on-track lesions versus off-track lesions is actually very low. So you may be overdoing remis.
Okay. So I just want to highlight this, that anti-instability is not synonymous with Bankart repair. There's more to it than Bankart repair. Many times you see that patient come with a prescription, shoulder instability, Bankart repair. So you have to keep that in mind, that almost 13 to 30% of Bankart repair have a failure rate. Okay, and that is because of poor selection of patients. So unless you have this thing in your mind, there is something more to it, you are going to fail. Now, how do you filter out those patients, Arjun, where you think that you will need to do something more than Bankart?
As I said earlier in my presentation, that it's based on, first, clinically you should suspect that this patient may have a bony defect. ease of dislocation. Most of them don't come with 1 or 2 dislocations. Many of them don't even remember the number of dislocations they had.
So increased number of dislocations.
Yes.
Okay.
And the other is the ease with which they can dislocate. Some of them just dislocate at night while sleeping and are able to reduce it themselves. That itself shows that this shoulder is very unstable and is with the ease with which it comes out. And others, while doing examination, if you find that patient is apprehensive even at just 45 degrees of external rotation, you don't have to go till 90 degrees. This will give you a rough idea that this patient has not a simple just a soft tissue defect, but a bony component as well. And then if you suspect this on clinical examination, you have to do a assessment, radiological assessment, which can be done by X-ray, CT, and MRI.
Okay, that I think we'll come to that in the next talk.
Sir, I had a question, sir, if you don't mind. I had a question for Harjoban and Dr. Shekhar and the whole panel. Now, this glenoid end-face view to quantify bone loss in the glenoid. Now, they tend to use this circle of best fit. Now, I've always felt that the glenoid is a pear-shaped structure. And a lot of times, this circle of best fit, when you're having differences of 5 and 10%, which could alter your decision making as to whether you're going to do an arthroscopic procedure or an open procedure. Is there any other tool you'll use to basically quantify the surface area while quantifying the amount of bone loss, like a region of interest tool or anything else? So I would like to have the opinion of the panel on this.
Okay, so Vikram, now it has been shown in the studies that if you compare both the shoulders, both the glenoids, then the difference is not more than 1%.
Mm-hmm.
Okay. Now, in most of the CT scan, they can take the CT of both the shoulders together. So you can compare with that. Okay. And as far as best fit circle method is concerned, you have to match the posterior and the inferior border. But then I agree with you that it's quite subjective.
Yes.
Okay. But still, if you can match the posterior and the inferior border, then it gives you a broad idea about the amount of the bone loss.
And also, you're comparing with the normal shoulder as well.
Yeah, that is fine. Normal shoulder is okay. It's just that circle of best fit that I was a little concerned about. So it always should be compared to the normal shoulder. That's done. Manit and Nandan, any other inputs on this?
Yeah, I think the best fit concept works, and almost all the measurements, especially with regards to bone lesions, are subjective. So even in the heel track, the on-track, off-track method, where we're calculating the glenoid track, it's really subjective on a CT scan where you mark the end of your rotator cuff insertion. Even the line that we draw to calculate the heel sacs index is subjective because it's from the medial edge of the heel sacs to the medial margin of the rotator cuff. Now, the medial margin for me may be a little bit different to the medial margin for you. So that can also introduce error and introduce bias into it. So that's why they do studies of inter-observer variability and reliability. And it's been shown over a progressive number of studies, as Shekhar sir was saying, it's probably the best of the current lot method.
And I would always look at the patient profile in such cases. So if you have a borderline bone loss, say around between 10 to 15% patient cases, 10 to 15% of bone loss in a contact athlete is to be treated in a different way than in a sedentary individual. So 10 to 15% bone loss. So the question is only in these borderline cases. So if it is less than 10%, we don't need to worry, 10 to 15%.
No, Nandan, my question is about calculation, not about management. Calculation of the bone loss.
So the best fit circle method, even if we take that, it errs a little bit. I would say in those borderline cases where it is erring, which you think, you should take the patient profile into your decision making. That is what I would say. So instead of refining the methods, I would say that we should take the whole clinical picture into our decision-making thing.
Okay.
Yes, these are all part of ICS score as well, the instability index severity score.
Yeah,
When I have a question for you. So when you have in your decision making, so when you have an athlete versus a non-athlete, just for the audience, I mean, this is that how does it influence your decision making? With an athlete, are you more likely to do an open procedure or are you more likely to do an arthroscopic procedure?
So more likely to do an open procedure if it tends towards this 15%, 20% bone loss. And if it is less, it's around that 10%, you can be more liberal with your remplissage.
So for a lesser bone loss, you'll be more likely to do an open for an athlete versus a non-athlete.
Yes, yes.
Patient profile matters a lot. Yeah. Now, in those cases where you are suspecting bone loss, which investigation would you prefer, Harjovan?
So I think for assessing bone loss, CT scan is still the best investigation.
Okay. So I think let's stop this topic here. So what I gather from your talk that the Bankart surgery has got a failure rate of almost 15 to 30%.
Yes.
Bone loss is one of the major cause. And if you are suspecting that, then you should send the patient for CT scan. Okay. Now with that, let's move on to the next talk by Dr. Manit. And he'll be speaking on the glenoid tract concept. Now, Dr. Manit is a shoulder surgeon and he's practicing at Fortis Mohali. And he runs one of the highest volume shoulder unit in North India. He's a faculty at AIMS and an associate at University of New England in Australia. He has got over 100 publications to his credit in international journals. And he mainly focuses on shoulder. So Manit, over to you.
Right. Thank you, sir. Thank you, everyone. I think that was a very good talk about decision-making in shoulder instability. And it sort of lends into this topic, which is the topic that I had picked out, was on-track versus off-track Hill-Sachs lesions. And I think that as our understanding of shoulder instability has evolved, we're now starting to pay even more importance to the concept of Hill-Sachs. So I credit my Hill-Sachs knowledge, however rudimentary it may be, to Professor Itoi. So I spent quite a time with him at Sendai in Japan at Tohoku University. And he's a really good guy, a very nice human being. And over a lot of sake and sushi, we discussed concepts of on-track and off-track. And it was a great deal of fun. So Hill-Sachs, what do we know about it? So there's some basic stuff about Hill-Sachs, which is they were discovered by two radiologists, 1940, which is Hill and Sachs. It's basically a compression fracture of the humeral head that's created by the anterior glenoid rim. So it's found in the posterior aspect of the humeral head. It's a common lesion that we see with anterior instability. It's found in about 65 to 67% of first-time dislocators, and it's more common in the recurrent dislocators. So recurrent dislocators, they typically have about 84 to 93% of cases have a Hill-Sachs defect. So the smaller Hill-Sachs lesions are located close to the greater tuberosity, and as the lesion gets bigger or you have a larger lesion, there's more medial extension of that GT. So you can see here, we've got a lesion that's your greater tuberosity, and it's quite close to it. Whereas if we look at this lesion, it's further away. So it's more lateralized compared to the greater tuberosity. So which of these two are more likely to engage? So that's just a question I want you to ponder over while we go over the rest of this talk. So what's the role of the Hill-Sachs in stability? It's primarily involved in end-range stability, not in mid-range stability. And they're two very different and important concepts to understand for the shoulder. There's mid-range instability and there's end-range instability. So the Hill-Sachs plays a vital role in the end range of motion. So as the humeral head moves through the mid-range, the Hill-Sachs is really not important. So you can see here, this is the Hill-Sachs defect on the humerus. This is the glenoid, and you can see the capsule is lax. So we're in the mid-range of movement. So in this position, the Hill-Sachs really doesn't have any role to play in stability. When the arm comes to the end range of motion, so when we're in that abduction external rotation position, the posterior lateral aspect of the humeral head will come and it'll face towards the glenoid. So you can see here the capsule becomes tight. We end up in that end range of motion. Now in this end range of motion, that's really where we want to assess the Hill-Sachs and its relation to the glenoid proper. So in this position, if your Hill-Sachs isn't entirely covered by the glenoid, it cannot cause instability. If it's more anterior to the glenoid, it has the potential to pop out, engage with the glenoid rim, and cause instability. So if you look here in the previous image over here, you can see the Hill-Sachs defect. It's completely covered by the glenoid in the end range of motion, and hence it's not going to be an unstable, or it's not going to engage. If we go to next image, you can see the Hill-Sachs. It's large, and at the end range of motion with the capsule tied, it's popping out anteriorly over the rim, and hence it'll engage and pop out. So this is an engaging. So the old term for these lesions were engaging and non-engaging, and now we're slowly diversifying from that, and we'll talk about that. So how can we figure out if a Hill-Sachs lesion will cause instability or not? So the risk of engagement dislocation depends on the size and location of the Hill-Sachs relative to the glenoid. And an important point to emphasize here is that the Hill-Sachs in a normal looking glenoid is very different to the same sized Hill-Sachs in an abnormal glenoid with bone loss. So it's a bipolar concept of stability, not only looking at the Hill-Sachs, but also looking at the glenoid. So if you've got a full glenoid with the same size defect, it's not going to pop out. Whereas if you've got glenoid bone loss anteriorly with that same size defect, it's much more likely to pop out. So again, we've got to look at both things, bipolar, look at the humerus as well as the glenoid. And there's two methods that we typically use for determining whether a Hill-Sachs lesion is going to pop out or not. One is the dynamic examination, which we do intraoperatively, and that's the sort of older tried and tested method, but there's a lot of controversy related to that. So that's why really the concept of glenoid track came, and it's a technique that we can use preoperatively. It's newer, and most of the newer studies are showing it's better. So in the dynamic method, what do? So we check the Hill-Sachs relation to the glenoid rim intraoperatively. That means that when we're doing our Bankart repair, so we see that how does the Hill-Sachs engage in that end range of motion, in that abduction external rotation with the anterior glenoid rim. Now, one of the big problems with doing a dynamic method is that a lot of surgeons do it before they do a Bankart repair. So if you do it before you do a Bankart repair, your anterior capsule is lax, and it really disturbs the true concept of stability. So you should only check it after you've done a Bankart repair. But here's the catch-22. When you're putting your arm into abduction and external rotation after a Bankart repair, you're also stressing the Bankart repair, and you may damage it initially. So that's why this method has sort of gone out the window. People still use it, but it's slowly fading away. And we still use it at times, but it's slowly fading away. So there's a good study by Park et al. In 2012. They looked at 983 patients. So pre-Bankart, there was 460 shoulders that they found that the Hill-Sachs could engage. And after doing the Bankart repair, only 70 of them engaged. So only 7% of cases actually had an engaging Hill-Sachs defect or an off-track Hill-Sachs defect that required a Remi plus Sarge procedure to be added. Whereas if we did it before we did the Bankart repair, 460. So that's why sometimes we're doing too much Remi when we shouldn't be. So in a pre-Bankart repair model, you can see here, you've got the Hill-Sachs, the glenoid, the capsule is lax. And again, we're testing it with a lax capsule before the Bankart, so that lesion may engage and pop out. Whereas after we do a Bankart repair and the capsule is nice and tight, that same lesion may not pop out. And if it is still popping out because this lesion is bigger to this lesion, then that means that it is a true engaging Hill-Sachs defect, which does require some fixation through a Remi. So that's why the glenoid track concept came about. So now everyone's talking about glenoid tract, and it's a very nice and neat way of doing things preoperatively. So the glenoid tract is basically an area of the posterior humeral articular surface that comes in contact with the glenoid as the arm moves through the end range of motion. So when our humeral head is rotating into that end range of motion, there's a stripe wear on the humeral head, which is the glenoid tract, which is the part of the humeral head which articulates or comes into contact with the glenoid. So if your Hill-Sachs lesion is sitting within this, then it will always face the glenoid and it won't pop out. If your lesion sits outside of this tract, it means that when it's moving into that end range of motion, your lesion will be bigger than the glenoid tract and hence can pop out. So if the Hill-Sachs lesion stays within the tract, it's not going to pop out. And if the Hill-Sachs lesion comes out of the tract, that means it's bigger than the anterior glenoid rim and it'll pop out. So how was the glenoid tract concept initially determined? So the width of it is the distance between the medial margin of the glenoid tract and the medial margin of the footprint. And the reason why we use these numbers 84%. So the initial studies actually showed it's 84%, but they were done in cadavers. Whereas the newest studies, which we're using now for 0.83, they're done in live shoulders, and so they're a bit more closer to the natural anatomy. So how do we measure this glenoid tract preoperatively? We use a 3D CT or routine CT, but you can also use an MRI, even though it's not that good. We basically measure the width of the glenoid and calculate 83%. This is what we call the 0.83D, capital D value. If there's any glenoid deficiency, which is little d, that needs to be subtracted from the bigger diameter. So the true glenoid tract is 0.83 times the diameter of the glenoid inferiorly minus any glenoid deficiency or bone loss, which is little d. So this width is then overlaid on the posterior part of the humeral head. Again, all of this is being done preoperatively, not inside the OT. And if the heel sac stays on this track, it's called an on-track lesion and it carries no risk of dislocation. Whereas if the heel sac's lesion is off-track, which means it's popping out of this glenoid tract, it will pop out once the head moves into abduction external rotation anteriorly. So now we've refined this concept further, or Professor Itoy has refined this concept further and is using something called a heel sac index. So if your heel sac index is greater than your glenoid tract, it's called an off-track lesion. If your heel sac index is less than the glenoid tract, it's called an on-track lesion. And that's a really nice, simple way. And I'll show you how to do it. So this is your CT preoperatively. This is your normal shoulder. So this is the D value that we were talking about before, which is the diameter of the inferior part. And 0.83D is your glenoid tract. So if we look at the shoulder in which there is anterior glenoid deficiency, so the value then becomes 0.83D minus D. So we take this value, put it onto the posterior aspect of the humeral head, and that calculates the two arms, the black arms of the glenoid tract. So we can see whether this lesion, the heel sac lesion, is sitting inside this tract or is it outside the tract. So again, here's another one, normal glenoid. You calculate the glenoid tract, as I think Dr. Harjoban also showed. So this is a lesion that's on track. So it's sitting inside this tract throughout the range of motion, and hence it's not going to pop out. Whereas in this one, where there's glenoid bone deficiency, we do the 0.83D minus D, and you can see it's a larger lesion, larger heel sac lesion, and it's sitting outside the white line, which is the glenoid deficient bone tract. And so this is going to engage, this is going to pop out. So this is an off-track lesion. Again, the same thing can be done on an MRI, and this is the heel sac index we were talking about. So it's a calculation from the medial part of the heel sac defect to the medial insertion of the glenoid to the rotator cuff footprint. And we can calculate this ratio, which is the heel sac interval over the glenoid tract measurement. So based on all this, based on all the studies, this is a really simple treatment strategy that we use for based on the glenoid tract concept. So if you've got an on-track lesion, less than 25%, do a soft tissue repair. On track with more than 25 bone loss, opt for a Latarjet. If you've got an off-track lesion, which is an engaging lesion with less than 25%, you should add a remiplissage. And if you've got an off-track lesion with more than 25% glenoid bone loss, your procedure of choice should be a Latarjet, plus minus a Remi, because remember with the Latarjet, you're also increasing the true glenoid width as well. So your lesion may not remain engaging, which is a topic for another day. So what is remiplissage? So it's an arthroscopic filling of the heel sacs using the infraspinatus tendon, which was initially described by Purchase in 2008. And since then, so it's only been 10, 12 years since it's come about really, and it's shooted up in popularity, and everyone's doing it, left, right, and center. But we should be very judicious in the cases we want to do it, because not all cases require a Remi. So if you've got an on-track lesion, you don't need to do a Remi. If you've got an off-track lesion, which is going to pop out, you should do a Remi. So if you see here, this is the heel sac defect. This is the humeral head. So we typically shave and blur and create a nice bleeding surface. We put in our anchor, so we like to use a corkscrew anchor from Arthrex for this, and we put that into our heel sac defect, and we use these suture passes to go inside, grab the sutures, and we're taking bites through the infraspinatus tendon when we're doing this. And then when we tie it down, that whole infraspinatus tendon comes down and fills over that defect. Again, there's a lot of things here about how many anchors you should use, where you should place it, and we're not going to go into all of that. But all the systematic reviews for arthroscopic Remi have shown that it's a very reliable, very good procedure with very low complication rate. And it does enhance your traditional Bankart repairs. So there's been multiple reviews that have come out, and it's been shown clinically and biomechanically that it leads to minimal changes in the range of motion, because one of the older problems was that people were saying that it was leading to a loss of external rotation. But we found, even in our practice and with studies as well, it actually doesn't lead to any significant difference in external rotation as long as you rehab patients properly. So in summary, Hill-Sachs lesions are important to understand. There's two methods. There's the older dynamic method, or there's the newer preoperative glenoid tract method. So glenoid tract is really now the resurgent force, and it's coming about. And for off-track lesions, we should be doing an arthroscopic remiplissage because it's a safe and validated procedure. And I can't leave you without saying that we live in the most beautiful city in India, which Dr. Vikram was saying as well before the talk. So once Corona is over, I really encourage all of you once at least to visit our city. Thank you.
Thank you, Manit. It was a very interesting concept and very nicely explained. So, friends, before this track concept came, the defects were considered individually. So if there was a glenoid bone defect of more than 25%, it was considered significant and lethargy has to be done. Similarly, if Hill-Sachs lesion more than 25%, it was considered significant. But what about those cases where the defect is 18 to 20%, but the patient is having a big Hill-Sachs lesion? So there is the importance of this track concept, because it combines both and it helps you in assessment that whether you need to do anything else, whether you need to add remplissage or an bony procedure. And you have explained it quite well, Manit. Now tell me one thing. In a practical scenario, most of our patients, they come with MRI. Okay.
Right.
Can you calculate these values on MRI?
So that's where Hill-Sachs index plays a big role. So the Hill-Sachs index actually can only be calculated on an MRI. So because it requires the dimension from the medial aspect of the Hill-Sachs to the medial insertion of the glenoid footprint of the rotator cuff print on a CT. So in those settings, we can do it. And obviously, the bony component of the MRI is never going to be as good as a CT, but it does provide us with a rough idea of where we're going for our surgery.
Okay.
I had a question for the panel again on the lines of Dr. Shekhar's question. I wanted to know how many of y'all for instability cases get a CT scan done along with your MRIs?
All cases get a CT. And
all your cases?
Yes.
Shekhar sir, Nandan?
Only indicated patients where I suspect that there is a bony defect which is going to affect my plan of treatment.
And other Nandan, Harjoban? Can't hear you. Unmute.
Sorry.
Yes.
So basically, for only on an MRI, I suspect some bone loss, or if I'm suspecting a bony Bankart, do I get a CT scan? Not in every blindly and not in every patient.
Same with me. Not in every patient. Only if I see the requirement to calculate bone loss.
And the other question, in a practical scenario, let's say you put in an arthroscope inside, you had anticipated a Hill-Sachs lesion. Ideally speaking, as Manit said, whether the Hill-Sachs lesion engages or not should be, ideally speaking, assessed once the Bankart repair is done. But that's not really practical. So according to all of y'all, when do you decide to do a remplissage in a patient, and when do you decide to leave it alone in a practical situation?
Practically, sir, we do it preoperatively now. So before we were doing it intraoperatively. So when everyone says that they don't want to do CTs in all of their patients, that's fine. And there is cost issues and everything, but we do a CT in all our patients because preoperatively now we want to determine glenoid tract. And if you're not doing it and you're using just a Hill-Sachs index, again, it's never going to be as good as a true glenoid tract. So that's when you get the surprises. That's when you get the unnecessary remiplassages happening, is when you're not using preoperative judgment. Proper planning before you take the patient into the OR is probably paramount. And I think Shekhar sir would say that as well. For planning for all cases is the most important thing.
Yeah.
Shekhar, practical.
But I understand Vikram's question because he also thinks on the line of Dr. Maheshwari. Okay. So Vikram, you know that there's also a intraoperative way of assessing your Hill-Sachs index or assessing this glenoid track. Now you have this bare spot, so you can calculate the amount of glenoid bone loss with that, because ideally the distance from the posterior border to the bare spot should be equal to the distance from anterior border to the Hill-Sachs. So that way you can calculate the amount of glenoid bone loss. You can calculate 83% of it, just because you are in a situation now. Okay, so that way you can calculate 83% of the glenoid, the defect in the glenoid, and you have remplissage in front of you. Okay, so it's a very crude method, but still you can have an idea whether this is this Hill-Sachs region is on track or off track. Okay. It's explained there in the literature also. So that way you can do it if your pre-operative planning has not been as good as Manit's and you are stuck in a situation. So that way you can do it. But if you are in doubt, then it's better to add remplissage. It adds 5 minutes to your surgery and you are much safer.
Sir, what do you feel about doing
that if you are doing letarge, then you are already increasing the R, and in most of those cases, the Hill-Sachs regions, they don't engage.
Right.
They.
So what about everyone else? Have you found that by checking after a Bankart repair, do you find it a practical method to do it? Because one of the problems, of course, is, that worry in our mind that are we going to overstress that Bankart repair?
No.
So I'll be frank, in my practice, I do maybe 1 or 2% of remplissage. Otherwise, more often than not, I tend to leave it alone, because I found that it creates stiffness post-operatively, and it becomes very hard for my physio to actually go through it. So I'm somebody who stays clear wherever possible, unless it's a very large defect and I can actually see it engaging, and I do not check it after my Bankart repair. So I tend to go against literature and tend to do it pre-operatively. Maybe I'm biased. I'm biased towards not doing a remplissage wherever possible, but I don't think I've repented ever.
But what's the rationale behind that?
Vikram,
yeah.
Now, these failures of Bankart, they can happen over a period of time, and that can extend up to 5 years. Okay, because as he told that these repair, they stretch out very slowly. And I have seen my patients coming back after 3 to 4 years. Okay, so I think we should go along with the literature. We should have a proper pre-op planning. And if it's a off-track lesion, then one should add additional procedure. Now, literature also says that there's not much loss of motion after remplissage. Maybe around 4 degrees, if I'm okay.
Yes, sir.
And I am quite liberal with remplissage. And frankly speaking, I don't see any of those patients behaving different from pure Bankart repair. So that comes to another question, that when you do remplissage, where do you put your anchors? Is it at the edge, the medial edge, or at the depth of the defect? Manit?
So I go towards the medial edge. So I don't like to go right in the center of the defect. So I try to, because that's the part that's going to engage first. So that's the part that needs to be covered first.
Yeah. Only thing is that if it's a very big, if the defect is extending very medially, and then if you put it near the edge, then you're putting a lot of tissue into it. So sometimes that may constrain the joint. Okay. Otherwise, you can put it near the edge of the ocular surface.
And does size dictate number of anchors for you, sir? Or?
Yes. If it's a big lesion, then we use 2 anchors. But most of the time, we get away with 1 anchor.
Right.
I think we should move to the next talk. And we come to another controversial subject, that's the slap repair. Vikram?
Okay, thank you so much, Dr. Shekhar and the whole team, and Manit and Harjoban. You guys did a swell job, and I hope I can kind of at least be half of what you guys did. And I really enjoyed it and learned a lot from you guys. So Brazilian Jiu-Jitsu is a rather, aggressive contact sport. So this was an interesting case of a gentleman who was a practicing Brazilian Jiu-Jitsu exponent as well as a teacher. who came to me with an unusual presentation. So he was 25 years old. He had a grappling injury 8 months before he came to me. So it's a contact sport. I'll show you a little later as to what exactly happens. It's for those who are MMA, it's a variant of MMA. MMA has kind of come through Brazilian Jiu-Jitsu. So it's, frank contact between two individuals. He did not have a frank dislocation, but about 5 episodes when he was grappling after that he felt that the shoulder wasn't okay. So I kind of, used my bias to interpret it as some kind of instability in the shoulder. He said he felt like his shoulder went out and came in, but he never gave any episode of a frank dislocation. On examination, there was apprehension, but I could, kind of attribute the external rotation pain to some element of pain happening in the shoulder. He had painful forward flexion of the shoulder, whether done normally or against resistance, with keeping the arm, extended elbow, and the arm in full external rotation, that is supination and pronation. So both of them were equally as painful. The cuff muscles, using the bias of pain, seemed normal to me. That means the power was all right in all the cuff muscles, and this patient did not have any generalized ligamentous laxity. Right? These are the MRI images. So this is the sagittal image. You can kind of ponder over the image a little bit. I will show you better images later on. This is more of a generalized image. More of the axial image of the glenoid end face. These are the other sections. Any inputs on this stage as to what you would anticipate when you put in your arthroscope? So let me ask the panel.
Let's start with Dr. Nandan.
Sir, as I'm seeing this MRI, if I'm not wrong, we have a slap tear which is extending more anteriorly with yes. So a slap tear which is extending more anteriorly. So that is what I'm able to make out from these limited pictures.
Dr. Harjoban and Dr. Manet, Dr. Shekhar, what else? Any other inputs with this?
We can see a slap tear on the coronal images, fluid going underneath the superior labrum, and also on the axial images, we can see this extending downwards anteriorly, looking like a Bankart, but not towards the inferior edge, but mainly towards the superior to the mid half of the anterior part of the glenoid. So I agree with Dr. Nandan on that. That looks like a.
Shekhar, sir, Manet, anything else other than that? Would you think you'd find?
I think the same.
Sorry, Manet, please.
No, sir. I think the same. I think that's what it looks like.
Okay. So 28-year-old. So first
25.
thing, 25. Yeah. So first of all, it's some sort of labral problem, instability problem. That's the first thing. So cuff is out of the thing. He complains of almost some kind of instability for 4 or 5 episodes.
Yes, 4-5 episodes.
Okay. So my first diagnosis or my first thinking will be that it's some sort of antro instability. Okay.
Correct. So I think that thing is quite clear from these images that we're dealing with an anterior instability. And I didn't want to use the literal terms for the lesion we were going to talk about, but some kind of a possible biceps pathology associated with it, with a normal cuff. All right. In clinical findings, MRI we could be plus minus about what we find arthroscopically.
Yeah.
So, Dr. Shekhar, you want to say something? I'm sorry. I think I'm.
Yeah, my first thing will be that it's a case of antro instability, maybe with involvement of biceps.
Perfect. So now let's see what we saw arthroscopically, right? So this is my arthroscopic findings. So this is viewing from the posterior portal. You can see a reasonable anterior labral lesion. and there is a slap tear associated with it.
So Vikram,
Yeah.
can you just stop it, orient everyone, which is the superior.
Okay, one sec. Let me just start again. All right, Dr. Shekhar, would you like me to be a little more specific?
Yes, you just orient that, which is the superior part of the glenoid.
Sure. So I'm viewing from the posterior portal. I'm looking anteriorly first, all right, so that you can see a labral lesion. I've turned my cable and I'm looking more towards the biceps and the biceps tendon right now. At the bottom is the glenoid, at the top is the humeral head. I'm placing my probe inside and I'm palpating the biceps footprint on the glenoid with it, and I can see a rent there. I'm going a little more inferiorly now and antero-inferiorly. And this is still viewing from the posterior portal. Now I'm viewing from the anterosuperior portal and looking down the anterior labrum. So I'm using a probe and here a shaver just to show you the extent of the lesion. So I think very, very well put by Harjoban and Nandan that this lesion was not extending all the way to the 6 o'clock position. It was more or less at about 4, 5 o'clock, I would say. The labral tissue anteriorly wasn't the best of labral tissue that I would like, but antero-inferiorly was a little better and a slap lesion. Now, would the panel now want to elucidate as to what would be the best line of management? How would you go ahead with treating this patient?
Yes, but before that, I would like to clear one thing to everyone, that most of the time you won't find isolated slap.
Okay.
Many times it is associated with either anterolabral tear or posterolabral tear. So you should always keep that in mind. Yeah.
Absolutely.
Okay. So,
regarding the management, any tips and points?
you can start with Manit now.
Sorry, I was just on mute. Yeah, I would just do he's a young guy, 25-year-old, right?
Yep.
So I would do a slap repair and do an anterior labral repair. And I would leave it at that. There was no heel sacks, no nothing else. So for me, I would just, if I was in and with this finding, I would just do a slap repair, put a couple of anchors up top and put some anchors at the front and just fix it. What I'm really interested, if I can just ask you quickly, is what's this cannula you're using? It looks very nice, the green color one.
It looks good, isn't it? It's a 5 mm cannula. It's the green cannula. I use it in knee arthroscopies also, works very well.
Which company is this?
It's locally made, so I get it made for myself. So I have somebody who makes it for me.
Nice.
Okay. So you will repair the anterolabrum and also do the slap repair.
Yes, sir.
Harjoban?
I'll also repair the anterior labrum, but I will just repair the anterior part of the slap and not go behind the biceps. Because doing repair on both sides of the biceps can sometimes make these patients very painful and very stiff. So I tend to repair the side of biceps which is in addition to the anterior or posterior instability and leave the other side as such so that they don't become stiff.
Okay. Nandan,
unmute. Can't hear you.
I would like to have more information regarding the extent of the tear posteriorly. So till what extent
it was not extending posterior, not at all. So you can take my word for it. I've checked it. Unfortunately, I didn't put it in because I just put in the pertinent findings.
Okay, fine. So there is a slap tear which
I think there's a signal problem.
So it is basically an anterior labral tear extending into the biceps root, if I'm not wrong, with no significant bone loss.
Okay, perfect. Anybody would leave? Yeah, sorry, continue.
So I would be repairing the anterior labrum and possibly avoid over constraining the slap region or the biceps root region.
So
if I understand right, you would leave the slap tear. You wouldn't do the slap tear, right?
So if it is extending towards the back, I would...
It is extending. Yeah, the slap tear is extending to the back, as I told you. But the posterior labrum is absolutely normal.
Okay, so the posterior extent of the slap, I would put one anchor to repair that slap also. So I would not leave the whole slap untouched, but only repair the posterior one, not over constraining the biceps root, and repair the anterior labrum.
All right. Any other inputs? So I think we can. Anybody for leaving the slap?
Or why can't you just fix the slap and leave the anterior labrum by freshening it up?
Good one. Yeah, absolutely. So, Manit, I was hoping somebody would come up with this, because this chap didn't give me any, though the MRI findings showed that there was a lesion, and I was tempted to repair it, of course, because you have a lesion there. His basic symptoms of what I could get out of it were mainly related to his biceps pulley rather than the instability per se, but then it's all subjective. So I'll have to kind of, clinically correlate what I see on the MRI and what the patient tells me. And seeing a lesion like this, many times it's a juicy lesion, so you think of doing both together, but very pertinent. And it did strike me also as to whether I just do the slap and leave it alone. I think, as Dr. Shekhar very, very rightly put, when you have a slap tear, more often than not, you have associated lesions. Younger patients, younger than the age of 40, more likelihood of having a Bankart lesion associated with it. And older patients, you may even have a rotator cuff. Over the age of 40, a rotator cuff tear associated with it. So that's our learning point here. When a slap tear is in isolation, more often than not, you would tend to treat them conservatively initially and then think of surgical management, as literature tells us we don't know too much about what's the best way with slap tears forward. But when you have it with a Bankart tear or a anterior instability, you're tempted to do both, because you know that the patient will get better because of his anterior instability. So I think that point is very rightly put by the wonderful panel that we have. And this is just for the audience. So these are the more pertinent images, and my arrows are pointing towards the slap lesion that you can see very, very clearly here, that the superior aspect of the labrum surrounding the biceps tendon has moved away from the glenoid surface. This is the anterior lesion that you're seeing, which is antero-inferior, but not all the way down. And the labrum seems to be quite dissociated from the glenoid. The other thing that I did find inside, that though the labral quality, the superior aspect of the labrum was good quality, below that it wasn't very great. So I needed to actually go down and liberate more and take my bites. And as you go more inferiorly, as Harjoban very rightly put it across, that below 5 o'clock, the labrum looked quite all right. All right. So this is what we had, a slap with a anterior instability. And this is again the slap lesion that you can see. So if we were to decide what is the lesion, so before, this was my surgical planning. So the brown is the glenoid, the red is the labrum and the biceps, which you can see upwards. And this is what we typically have. It's a lesion it's a slap lesion. That means a dissociation of the biceps the biceps pulley on the glenoid surface, as well as it was extending antero-inferiorly. So because it was a slap tear with a Bankart tear, we could call it a type 5 slap lesion that we have here. The biceps tendon was all right. So it was basically just the pulley part which was involved. So my scope is the black structure coming in. I'm seeing from posteriorly. The green cannula is my antero-superior cannula, very close to my biceps tendon. Now, it's very important to have this cannula a little flexible if you intend to do a slap repair and repair the posterior aspect of the slap. As Harjoban very rightly put, he wanted to go just anterior, and I completely respect that decision, because literature has shown that putting a posterior anchor to some extent can limit rotation later on. And you have an anterior cannula, which is my working portal through which I take my bites onto the labrum. That is the pink cannula that you can see. So the labral repair was standard. I will show you in the video how I do it. But I put my preferred technique of choice is putting 2 anchors and taking simple sutures, one at 11:30 and one at 12:30 position. And I use a bird beak to take a bite to the capsulolabral region and tie a sliding knot. And this, you can see that the green cannula should be flexible, and you should be able to go behind the biceps tendon to put your posterior anchor to do your slap repair. Now, this is what my whole construct, my intention was to have this construct, an anchor anterior to the biceps tendon, an anchor posterior, very close to its insertion, and 3 other anchors distally. Because of the bad, the labral tissue quality that I anticipated, I thought I might have to take some mattress sutures in my labral repair, which I did for one of my sutures to get a better hold. This is a standard technique that I use. I use a liberator first to basically liberate my labrum, then a rasp to clear up the surface and to make it a little fresh. Use my radio frequency probe to mark my anchors. Then I like to use all suture anchors in all my intra-articular work. So I use all sutures here, and you can see it going in. I like to use a standard suture passer. I hold my labrum with a grasper when I take my bite to have some element of capsular shift when I'm taking my bite. Use the standard SNC knot for my distal anchor that you can see here. My next anchor is at 330. This was the one where I used mattress suture, and the third at 2 o'clock position. I'm not dwelling too much on the Bankart. I'll focus more on the slap. So you can see the labral tissue coming closer. I took some element of capsule along with it because it wasn't great. This was my slap preparation. I prepared it with a rasp again and a liberator. And this is my cannula very close to the tendon, which gives me that plate to put my anchor in there. It should come superior to inferior because it gives you that, the tack which you can push against the humeral head while putting your anchor in. And this is my anchor going in. This anchor helps me, this cannula helps me introduce a bird beak. So standard, just put the bird beak in. Make sure you don't violate the biceps tendon. Take one bite, and then I use an SMC knot very close to the biceps insertion, and I tighten it there. Cut my 2 ends of the suture. Now you can see that I'm going to move this cannula posterior to my biceps tendon. This is critical to have this place so that you can go at the back. It's very easy then to put in the anchor there. And again, an all suture going in. Use the same bird beak to take my bite and a standard SNC knot at the end of it that secures my slap lesion there. It's just a matter of preference that I like to put a posterior anchor along with an anterior one. This is my construct anteriorly, and then I'm basically checking whether it's back in place. And this is my slap repair at the end of it. Any inputs on the same? Would anyone have done this any differently?
Very nicely done, Vikram.
Thank you, sir.
Only thing is that when doing a slap repair, you have to be aware of over-constraining the joint. This is the case of Bankart tear along with slap tears, so it's okay. But in isolated tear, nowadays, most of these injuries are because of this peel-back mechanism. And it's the posterior part which is mostly avulsed. So you should avoid putting an anchor anteriorly because that really restricts your last degree of external rotation which these throwers require. So in those cases, one should avoid putting an anchor anteriorly. But here it was associated with Bankart lesion, so I think it's quite good. Yeah.
Nandan's very excited. Tell me, Nandan, I'm waiting to hear you.
I would move away the slap anchors a little bit away from the biceps root from where you have put it. That is my first thing. And second thing, there are many people, there are many orthopedic surgeons, arthroscopists who are coming out with something called as a knot ache. So knots around the biceps root usually end up irritating it. So I would prefer knotless anchors when I have to do slap repair. So the only 2 additions which I would probably change in what you have done right now.
Yeah.
Very pertinent point. Knotless anchors are very good in using them in slap repairs. I agree with you. Manit, anything else?
No, sir. I think it looks very neat and very good. I have a general comment for the panel, which is something I wanted to ask everyone, if that's okay, which is that now there's a school of thought, right, which says that we should shift away from slap repairs and towards biceps tenodesis. So what does everyone feel about that? So
Manit, very pertinent point. So Boileau's paper, where he evaluated, the slap repairs that he did versus the biceps tenodesis in 2009, if I'm not wrong, actually elucidates your point. And it says that the ones who did just a biceps tenodesis did very well as compared to those that had a slap repair. So I think the world is going away from this, especially in contact athletes and athletes that are overhead throwers like baseball pitchers. Luckily, we don't have them in India.
Right. So I think in a way it's different to our meniscus, right? Because in the meniscus, for the younger patient, the more athletic patient, we're more concerned about meniscal preservation. Whereas here we're shifting away from it towards, tenodesis. So we're actually violating the sanctity of the slap.
More importantly, Manit, if you look at the blood supply to the anterosuperior region of the glenoid and the labrum, it's a watershed area which is slightly devoid of blood supply. So healing in this region is questionable at times. So I agree.
Like a meniscus.
Yep.
We should move to the next talk. But
no, yes. I have a couple of things just to finish off. This is the MRI post 3 months to show you that the slap lesion is back in position. You can see my anchors there. And this is the chap back to sport. I think I was lucky because it worked in him. But, it's about 3 years follow-up. But, of course, we go with evidence and we see whether, tenodesis in future is a better alternative to just a slap repair. Thank you very much.
Thank you. So slap still remains controversial.
Absolutely.
The diagnosis remains controversial. The treatment is controversial. Now, previously, people used to do slap repair left and right. But as the results...
That contributed to it.
And as the results came, then slowly people have now moved more towards biceps tenodesis. I think still in young patients who are really young, 20, 25, and they're in active sports with good labrum, the slap repair still has got value. But especially patients who are above 30, their biceps tenodesis works better than slap. And yes, you should not over-constrain the biceps because then it becomes quite painful. Right. So with this, I think we move on to the last talk by Dr. Nandan. And he'll be speaking on posterior capsular posterior labral tear. Dr. Nandan is now is a consultant at Unity Hospital, Surat, and also as a Unity Orthocare Kadodara. He is visiting consultant at most of the leading hospitals in Surat. So I think he's the master arthroscopist of Surat. So with that, Nandan, you can start your talk.
Good afternoon, everyone. So at the outset, I would like to thank all the organizers and the panelists for such a wonderful session. So after all these enlightening talks on shoulder instability, I would be presenting my talk on posterior shoulder instability. So posterior shoulder instability is really a spectrum of disease. And this is the outline of my talk. I would be briefly introducing the posterior instability. Then I have 3 cases to present, followed by a general overview of the posterior instability. So posterior instability is a spectrum of disease. The lowest part or the least mild part of this disease is incidental finding with predominant anterior instability, patients presenting with posterior subluxations with no labral tear, and as a part of multidirectional instability. The spectrum goes all the way, and patients who have a little more serious or a severe presentation have posterior shoulder subluxation with a labral tear with a reverse Hill-Sachs, which may or may not be present. Next, you might have patients with a posterior shoulder dislocation, a posterior labral tear, a reverse Hill-Sachs, and sometimes glenoid bone loss. And the most severe presentation is patients who present with a fixed posterior shoulder dislocation. So I'll start with the first case. So this is a 24-year-old kabaddi player with 3 episodes of possible subluxations. This is his dominant arm. The first episode was due to a fall on an outstretched hand. He complained of pain posteriorly in the shoulder, and all his clinical signs for posterior instability were positive. On the MRI, he had a posterior labral tear from 6 o'clock to the 9 o'clock position. There was no glenoid bone loss. There is a small reverse Hill sacs, and the glenoid retroversion was approximately 5 degrees. This is the intraoperative picture. So I'm visualizing through the posterior portal. So there is a complex posterior labral tear with a patulous or a very capacious capsule posteriorly. There is a normal, we now shift to the anterosuperior portal. There is a normal anterior labrum and a complex bucket handle tear of the posterior labrum with a complete sleeve of posterior labrum avulsed from the posterior glenoid. Coming anteriorly, there is a small reverse Hill sacs lesion. So we start with of the posterior glenoid. A small cartilage edge is removed to facilitate anchor placement. This is assessing the release. The anchor comes in. Here you can use suture tack, fiber tack, or any of the Arthrex anchors which you prefer. I preferred this. Now through the accessory posterolateral portal, the instrumentation is coming and we take sutures in an antegrade fashion. So basically the suture has to pass caudally or inferior to the anchor so that we get a posterior capsular shift with a retensioning element. So this is again a retrograde passage of the So the suture is again, the bite is again inferior or caudal to the anchor, suture anchor, so that at the end when we tie the sutures, we get an element of posterior capsular shift and retensioning. This is the knot tying part. So the posterior capsule is nicely bunched up and the posterior So the next case is a 24-year-old rugby player. This is his first time traumatic dislocation. This is the CT scans during the first time. Close reduction under general anesthesia was done. He underwent subsequent rehab and he returned to sports at 4 months. He again suffered a second dislocation during a game, and this was his CT scan where he had a posterior dislocation. He again underwent a close reduction under general anesthesia, and we later planned for an arthroscopic labral repair with a McLaulin's procedure. So this is the arthroscopic picture. So again, visualizing through the posterior portal, on your right is the caudal part of the glenoid, and on your left is the cranial part. So this is the posterior labral tear. Visualizing through the anterosuperior portal, we can see the posterior labral tear extending from 6 o'clock to 10 o'clock position. A normal anterior labrum and a rather large reverse Hill sacs lesion. We go ahead with preparing the posterior glenoid. This time I preferred a all suture anchor. So again, the same principles of passing the suture inferior or caudal to the suture anchor to achieve a posterior capsular shift. And this is the second anchor. This is again an all suture anchor and a retrograde passage of the suture. Tying the sutures, we get a good posterior labral repair with a posterior capsular shift and a retensioning. We now turn our attention towards the reverse Hill sacs lesion, freshening up the defect. We clear the rotator interval and a space anterior to the subscapularis. This is anchor insertion at the caudal part of the reverse Hill sacs and suture passage through the tendinous portion of the subscapularis. You have to take into mind that the stitch should come at the level of the anchor, neither medial nor lateral nor superior nor inferior, because we don't want to retension the subscapularis. We just want to fill in the reverse hill sacks with the subscapularis. So the reverse hill sacks lesion gets filled with the subscapularis tendinous part with the help of vertical mattress sutures. So this is the vertical mattress sutures. A retensioned posterior capsule and an anterior capsule which is again retensioned because of the McLaughlin's procedure. That is the axillary nerve which we have dissected and has been protected during the repair. This is the post-op MRI at 1 year, which is showing that the defect has been well filled in. The last case which I'm presenting is a posterior fracture dislocation. So this is the MRI and the X-ray. This was a 27-year-old female. She had an electric shock at home. She was later immobilized in a shoulder immobilizer for 3 weeks. The whole injury was neglected. When she came to me, she was not able to move her shoulder. The movements were all very painful, and this was neglected for 3 weeks. We went ahead with open reduction and fixation. So deltopectoral approach, we first raised the biceps tendon, and with the help of biceps tendon, we opened the rotator interval. We inserted a finger through the rotator interval, and with the help of some instruments and maneuver, we reduced the shoulder joint. So this is the shoulder joint reduced. I'm holding the lesser tuberosity fragment in my tooth forceps, and the biceps is tagged with a vicryl stitch. Then the fracture fragment was medialized and fixed with 3 screws and 2 transosseous sutures using a fiber wire. So my artery is on superior transosseous sutures, and this artery is on the inferior transosseous sutures. And this is the transosseous sutures tied at the back of the humeral head. This is the intraop stability of the proximal humerus and the X-ray, post-op X-ray. So after these 3 cases, we'll move towards the general overview of posterior instability. So how do you evaluate recurrent posterior instability? So usually these patients are quite different from anterior instability patients. They do not have apprehension like anterior instability patients. They have vague complaints which include a posterior shoulder pain, weakness, clicks inside the shoulder. Some of them will come with a history of fall on adducted and internal rotated limb. Frank dislocation otherwise is uncommon in these patients. If you are suspecting a dislocation, a true AP, axillary and scapular Y-view is necessary. Clinical tests for posterior instability include a posterior drawer test, posterior load and shift test, and the Kim's test. On MRI, you will have a plethora of pathological findings apart from a posterior labral tear and a reverse hill sacs. So this is known as a polpsa lesion or a posterior labral labrocapsular avulsion of the posterior periosteum. So this is known as a polpsa lesion. Sometimes you can see bony Bankart of the posterior labrum. This is glenoid dysplasia with a hypertrophied posterior glenoid labrum. This is a Kim's lesion. Kim's lesion is essentially a partial tear at the junction of the labrum and the cartilage. And sometimes you might have a reverse Hegel or a posterior Hegel, which is known as P. Hegel. So this, in short, I would, without going into the complexities of posterior instability, I have prepared a short summary of the treatment of posterior instability. So basically, there can be soft tissue lesions, there can be bony lesions. Soft tissue lesions may be in the form of labral tear, a subscapularis tear, or a posterior capsular laxity. Bony lesions may be in the form of reverse hill sacs, a glenoid bone loss, or glenoid retroversion. So if you have a labral tear, repair is the answer. If you have a subscap tear, again repair is the answer. Posterior capsular laxity patients usually present in the form of as a part and parcel of multidirectional instability, and in such patients, posterior labral plication is an answer. Bony lesions are next, and we'll see them later. So treatment of bony lesions in posterior instability is more controversial. Posterior instability is usually not the mirror image of anterior instability. So the treatment recommendations are not yet so concrete, but still I have tried to summarize them. So if you have a reverse Hill-Sachs lesion and a size of less than 10% of the humeral head, then only a labral repair would be enough in most of the patients. If the size is more than 15 to 20% of athletes, an arthroscopic McLaughlin repair would be needed. If there is glenoid bone loss and it is less than 15 to 20%, again, labral repair would be sufficient in most of your patients. And if the bone loss is more than 15 to 20%, a bony posterior augmentation might be needed. The last topic of glenoid retroversion and glenoid dysplasia is still controversial. There are many studies coming out with ideas of treating these patients, but there is nothing concrete. As such, patients with glenoid dysplasia, again, a bone block surgery is controversial, whereas in patients with retroversion more than 15 degrees and in the setting of revision surgery, the usefulness of osteotomy is still being investigated. Some technical pearls while doing posterior instability, I usually operate in the lateral position. So the posterior portal is 1 centimeter lateral to the usual site in line with the lateral border of acromion. This is to facilitate a vertical trajectory towards the posterior glenoid. You might have to make a posterolateral portal, which is again 1 to 2 centimeters lateral and caudal to the posterior portal. You need to always locate it with a spinal needle. So this posterior lateral portal is useful for reaching the lower half of the posterior glenoid, which might sometimes not be possible with your classical posterior portal. Anterior-superior and anterior-inferior portals are the same as of anterior instability. You might use an inferior and posterolateral portals. Ready. So sometimes if you're not able to reach the difficult positions, you might be able to use these curved guides and anchors to insert your anchors in the posterior glenoid. Thank you.
Thank you, Nandan. That was a great presentation. A very comprehensive review of a problem which is not as common as entry instability. Now, most of the patients with subtle posterior instability, they don't have very clear-cut signs as in entry instability. So, what are your guidelines? How do you examine these patients and how do you arrive at a diagnosis, the clinical diagnosis part?
Sir, due to the patch, I could not get the question correctly. Please, could you repeat the question?
Okay. So, what are the usual clinical symptoms and signs with which these patients present?
So, starting with the clinical complaints, usually they have an index injury. The index injury is either in common population. They have a fall on an outstretched hand, or an injury while something jerk to the hand, or a throwing injury, somewhat of that sort is present if you ask them on clinical presentation. Second, they'll always complain that whenever they are trying to reach out to an object, they might be having some or the other click in the posterior part of the shoulder. Next is pain in the posterior part of the shoulder. So these three are the most common things which I note on history. Next is on clinical examination. Classically, these patients, if you do the anterior labral tests, they are fine. But as soon as you go into the 3 labral tests which I've told, you might have almost 70-75% patients, you will find symptoms of this. I would rather accept that 20-25% patients you can't come at a diagnosis clinically. And it is only on MRI that you come to know, no, he has a posterior labral tear, and retrospectively you go back to the patient and find out that he has posterior labral signs. So those 25 to 30% patients, you never get to make a clinical diagnosis, except that you find something is wrong with this patient, he is not doing well.
Okay. And when you do this provocative test in this posterior instability,
Yes,
most
sir.
of the time the patients complains of pain rather than apprehension.
Yes, sir. Pain more than apprehension. Pain is more severe. And this posterior draw test, it looks a little bit gory. And so I don't do it as the first test. I rather prefer the load and shift test more towards and the Kim test because it is less painful. With the posterior drawer, patients have a lot of pain because you are trying to push the humeral head posteriorly.
And how do you differentiate these patients from the patient of posterior instability seen in multiligamentous injuries or multiligamentous instability?
If you are asking me clinically, sir, so clinically you can do a sulcus test, one, a Gege's hyperabduction test, and then anterior label. So multidirectional instability patients will have signs which are positive in all these tests. So then you come to a clinical diagnosis, it's not only posterior, it's inferior, it is going towards the rotator interval, it's going anteriorly everywhere.
Okay.
I have a question for the panel. Good job, Nandan. In multidirectional instability with a circumferential lesion, if you ever decide to arthroscopically treat it, how do you fix it? Do you go 360 degrees? Yes, you go 360 degrees. And if you were to tighten it, you do which direction do you do your scapular shifts in?
So you're talking about multi-directional instability
with a posterior lesion, so circumferential. So there is a dissociation of the labrum all around the glenoid.
Okay. So mostly in multi-directional instability, you don't see actually a lesion there. It's basically a capacious capsule. There is problem with the collagen. The capsule is not working fine. Now, what you are explaining is a labral tear throughout
circumferential labral tear.
Circumferential labral tear. So if it's a circumferential labral tear, then it has to be repaired. If it is associated with some sort of capsular laxity, then what I try to do is just to reduce the volume of the joint. So you can take a bigger bite of the capsule along with the labrum and just try to reduce the volume of the joint. That's what you can do.
So nobody focuses on doing a capsular shift in any direction in an MDI. I mean, in a circumferential lesion. That was basically where I was getting at.
Well, if it's multi-directional, then how are you going to do the capsular shift? Which direction? It seems that...
Would you do it or would you not do it?
No, you will be doing some capsular shift because you are anyhow pulling the capsule up posteriorly as well as anteriorly.
Mm-hmm. Okay, so in both directions.
Yeah. So my thing will be just to reduce the volume. I haven't done it, but that's my thinking that I would just like to reduce the volume of the joint. What's your take on that?
As Dr. Shekhar says, I agree with the fact that the bite should include quite a bit of the capsule with it. But I always had this dilemma: which direction do you do more of an anterior capsular shift or more of a posterior capsular shift? How do you decide on tape? Anyone else? Manik, Nandan, Harjoban?
So,
experience with this?
Anchor placements, it's bilaterally symmetrical. You can't do only anterior, then come to posterior. So if you have a 360 degree stare, so you go both inferior first, try to take a bite which is symmetrically pulling up the capsule. So you do a capsular shift which is symmetrically on both the sides. So anterior inferior goes, posterior inferior goes, then you come symmetrically. Then you can put all posterior, then come anterior. But the inferior capsule along with the inferior labrum has to come up as one single unit with decreasing the volume inferiorly, because it's very difficult to put that 6 o'clock anchor. There is an auxiliary portal from which you can come and do all that stuff, but in the routine practice,
yeah, would you put a 6 o'clock anchor or one at 5 and one at 7?
I have never tried that auxiliary.
No. So from what I get from you, you would put a 5 o'clock and a 7 o'clock.
One at 5 and one at 7.
That's what exactly. So, yeah, perfect. Anyone else?
Hello.
I think Nandan, it was a very nice presentation, and you showed the whole spectrum of the posterior instability. In the first case which you showed, there was dissociation of the labrum from the capsule. Can you hear me?
Yes, sir. Please come back with the question, sir.
So the first case which you showed, the labrum was separate from the capsule.
Sir, that small piece which you are able to see, I think that was that bucket handle piece of the labrum.
Okay.
And that was debrided off.
That was debrided. Okay.
Yes.
And for your McLaughlin procedure, you make sure that the length of the tendon of subscapularis is intact. It is not shortened.
Yes. So we make sure that if the anchor is at this level and the subscap is lying like this, the stitch should go like this. It should not go like this to pull the subscap into the defect.
Okay.
That causes all problems with external rotation deficits and all. And it has to go parallel, bang parallel.
And does the position of the arm matters?
Sir, we usually do it in a neutral position. It's neither external rotation nor because if you do external rotation, the gap closes down. And if you do internal rotation, you'll pull too much of the subscap into the joint or the reverse Hill-Sachs lesion.
You have to be aware that your arm is in neutral rotation, because sometimes when the patient is in lateral position, the arm may be internally rotated like this. So you have to be sure that it's neutral rotation, or else you may just
neutral rotation.
I think it was a very nice presentation, and I thank all the faculty who prepared so well and almost discussed most of the aspects of the shoulder instability. I also thank the Cure Academy for arranging this program, and Ashok of OrthoTV for arranging this meeting. So thank you very much, and let's hope to see you again. Bye.
Yes, see you.
Thanks a lot. Wonderfully moderated, Shekhar sir. It was very nice and very exciting.
Thank you. Bye-bye.
Bye, sir.
Thank you so much.
Thank you.